So hey everybody, I'm Desi Shu. I'm one of the assistant professors, neurologist, and lateral skull-based surgeon at The Ohio State University Wexner Medical Center. And today I have Kara Gillum and Jennifer Miller, who are both physical therapists that I've had the pleasure of interacting with in the past several years, taking care of patients with different vestibular disorders. And today we really want to take the opportunity to discuss a topic, I think, that sometimes is underappreciated or doesn't get all of the focus that it should, because the things we'll talk about today really can have an important impact on everybody's quality of life, especially those with vestibular disorders. Of course, we want to thank the Children's Tumor Foundation, the NF Summit, for inviting us, and all the organizers. It's really a pleasure for us to be able to be here and talk to you guys today. So quickly, just to review some of our objectives, and really we're trying to answer some relatively common questions related to vestibular dysfunction and how it may relate to a patient with an acoustic neuroma or vestibular schwannoma. There we go. So one of those is just what symptoms can one with NF2-related schwannomatosis expect related to their vestibular system or their balance system. What can I do as a patient to help manage my symptoms? And then what is vestibular rehabilitation? And so this is one of our mainstay as far as treatments for patients with vestibular disorders, and can really have a strong impact on the quality of life. And then, what goals do you set for yourself, or what is the outcome that you guys should be expecting? And then probably most important is, how do you find one of these mystical vestibular rehab specialists? They are in the community, but sometimes they're not as well advertised as they maybe should be, especially for patients with problems. And so then just to start, as far as, we'll be talking kind of mostly about the vestibular system, which is a part of the inner ear next to the cochlea, the hearing organ. But I do want to take a moment and just say that balance function and balance sensation as a whole is quite a complex system and signaling pathway that involves not only the inner ear and the vestibular system, but also our visual fields and our ability to see and interact with the world that way, as well as what we call proprioception, or our brain's ability to know where our limbs and our joints are in space and in relation to each other. That system's, the way I think about it is that system is responsible for allowing us to scratch our nose in the middle of the night without poking ourselves in the eyes, because our brain knows where those limbs are. And then all this information gets compiled and processed by the brain. But specifically, the vestibular apparatus, the vestibular system, is what we think of it as an inertial sensor for our head's motion through space and its position in space as well. And it really drives a lot of different reflexes, but most importantly, from both a testing but also functional perspective, is it really helps us to stabilize our gaze so that we can see our visual field clearly as our head is moving. And so this just shows where that vestibular system is. It sits behind the eardrum in the temporal bone of the skull, at what we call the lateral skull base. It's in continuity with a part of the cochlea, the inner ear, and so both the inner ear hearing and balance functions have a lot of overlap and a lot of similarities through development and through dysfunction with other processes. And then, as one could expect, if there was a problem or disorder with the vestibular system or along the nerve that carries that signal from the balance system to the brain, patients could experience a number of different symptoms, including imbalance, as well as dizziness. And then these patients are also at increased risks of falls and those injuries that can occur with falls. And that's why I think it's so important to talk about this topic more. Vestibular function, again, helps to stabilize our gaze with our head movements. And so this shows this reflex arc, which we call the vestibular ocular reflex. It's actually the shortest reflex arc and the fastest one in our body. And it's primarily tasked with always providing an eye movement that is equal but opposite to any head movement you make. And what that does allows our visual field to be stable, and allows you to do things like see faces, read signs as you're walking or moving through the world. And this also, again, kind of all reinforces some of those other vestibular imbalance signals that go to the brain. And again, so this just shows kind of that pathway, the image below. And then the way we think about the VOR is through the VOR gain, and that is a ratio or a number that we give to it as far as how well the eye velocity or the eye movement is matching the head movement or velocity. And so we'll talk about this a little bit more in just a little bit when we talk about some of the testing that we can do and how we use this for diagnosis as well. And again, just the presence of a tumor along that nerve could impact this reflex and other vestibular functions as well. So vestibular schwannomas are tumors and growths of the supporting cells, the Schwann cells of the vestibular nerve. And they come in a lot of different, while they have to occur along the vestibular nerve, they can show up in a lot of different locations along that nerve. They can show up in different sizes and at different growth rates. So there's a lot of variability, and oftentimes, we have to take that into consideration as far as other things that may be driving or causing some imbalance. Most often, it's just from direct involvement of the nerve itself, and then those images on the right really kind of are just some MRI images showing that variability in the different sizes, and it's paired with a grading system that we sometimes use clinically to describe these more, and it essentially shows that they can be tiny tumors inside of that bony canal, the internal auditory canal that carries the nerves from the ear to the brain, but it can also occur outside of that or extend kind of throughout that whole area. And of course, patients with NF2 and associated schwannomatosis can often have these tumors in both sides, which can provide different challenges, which we'll also talk about. So what are the common symptoms of an NF vestibular schwannoma tumor? So the most common one that patients present with is hearing impairment, either unilateral or bilateral, often in both ears if there's a tumor in both sides. And then tinnitus, which often pairs with the hearing impairment. So the brain's kind of attempt to make sense of that lost or diminished hearing signal. And then where we, again, focus some of our attention is the dizziness and imbalance that can come along with that. And again, with that diminished vestibular function, we think about the gaze instability that might come along with that. And if it's severe and impacting both ears, many patients will describe this symptom called oscillopsia. And that's really this blurry vision, this difficulty stabilizing the gaze with any head movement. And so I think in just a little bit, we'll show you a video of what that may look like or what patients describe that to look like. And then there's been some more recent research looking at the role and importance of the vestibular system in spatial orientation and navigation. And so it's not just kind of the balance that you see in front of you, but also may actually reach into how you navigate the world around you and how you kind of recall different locations based on your experiences. Motion sensitivity, this again is just sometimes it can be a little uncomfortable when the ear isn't providing the strong signal to the brain about where you are and how you're moving through space. Sometimes these tumors will present with primarily facial weakness or asymmetry, so it's important to consider that too. That's another nerve that runs through that bony canal with the hearing imbalance nerve. And then ultimately, all of these things together can cause patients to feel more fatigued and more mentally fogged and worn out. And we think that that's likely related to just the mental effort that it takes to interact and navigate the world with all these different kind of sensory impairments that the brain's trying to overcome. And so this is just that video of what oscillopsia looks like. So this is just somebody driving in a car. The way I think about it is it's almost like watching an old VHS before Steadicam was a thing. There's just the eyes aren't moving opposite to the head. So everywhere the head goes, the eyes kind of bobble along with it. And that can be very disorienting. People often talk, and this is, again, most often occurs in patients with bilateral vestibular dysfunction. It also often comes along with a sense of wobbliness or kind of a really disabling sense of disorientation and imbalance. And so it's important to kind of have an idea of what that looks like, because some people may even be experiencing this and not know that there's a term or a cause for it related to the ear. And then this highlights that vestibular ocular reflex. What you can see is when they do head movements towards the left, the eyes stay focused on the camera, but when they move to the right, the eyes drift off and then jump back. And that jump back is what we call a refixation saccade. And so a normally functioning vestibular system will keep the eyes on target during these quick head movements. But if the vestibular ocular reflex isn't sufficient enough to really counteract the head movement, the eye will actually move with the head. And then because you've given them a task like look at your nose or your eye, the eye will jump back. And so this is a test that we do in the clinic to look for problems with the vestibular system. We can also do a laboratory-based test called the video head impulse test, where we pair high frame rate goggles with motion sensors. And really what we're trying to do is we're trying to quantify how quickly the eye is able to move compared to how quickly we're moving the head. And so just a quick key here, the blue and orange trace is the head movement. So the head movement on the left, and then the orange is the head movement on the right. And the green is the eye movement in response to that. So in this patient, for instance, they had normal function in their left ear, so the eye trace almost perfectly overlaps the head trace. And there are just a few eye movements after the head comes to rest. And then in the other side, you see both that green line doesn't quite match that orange or red line, which means that the eye isn't keeping up with the head movement. So the vestibular ocular reflex is not being driven strong enough to kind of stabilize the vision. And then those little spikes afterwards are actually those refixation eye movements, or the eye jumping back to the target. And so through this, we can actually calculate the gain. So on the left, that number of how fast the eye is moving compared to the head is about 85% or 0.85. And on the right, it's lower than that. It's 0.4 or 44% of what it should be. And so a normal gain, we kind of qualify as anything above 80% of that. And so again, this is similar to the video I just showed you. This lady would have, or this person would have a right-sided vestibular hypofunction or unilateral loss. And so there's that. And then the last thing I just want to show is some of the functional impairments that patients have. So their walk can be altered. They can have problems usually with a cautious and broad-based gait. And again, they're at increased risk for falls. And so, again, this is just all kind of a general overview of both what the vestibular system is and does and what some people will present with as far as symptoms go. And so now I'm actually going to hand it over to probably the bigger chunk of the talk today to go through what the treatments are, what vestibular rehabilitation is, and how can that impact a patient with NF's life.
All right, so treatment, sometimes this can be prior to somebody having a schwannoma removed. If surgery is not an option, then it still would be appropriate to improve overall balance and mobility, or after a schwannoma might be removed. So I'm just gonna go through what our typical vestibular rehab program might look like. Again, we individualize it and specialize it depending on the person and what makes most sense for you. But there's a couple different types of exercises that we do. So the first one is gaze stability exercises. So that's why these X's are out on your table. We'll let you interact a little bit if you would like to. And then we also do balance exercises as well. So typically for the gaze stability, we want to work on adaptation. So trying to help optimize that reflex, retrain your brain, how to keep the eyes focused while you're having head movement, so that way then that can apply to more community mobility daily activities. And then for our balance exercises, we want to optimize function of the systems, the balance systems that you have intact. And then also, if your vestibular system isn't as intact, but then you have a surgery, then we want to make sure it's working as well as we can. So if vision is impaired, then we want to focus more on that proprioception, your ability to feel where your body is in space, and vestibular function, or any combination of those three systems as well. So the first exercise for gaze stability, it's called ×1 viewing, and that just means that only your head is moving, the target stays still. So if you were moving your head out like to scan, look around the room, but your eyes are staying focused ahead, then that's what that movement would be. So if you want to interact, go ahead and grab the X's on your table. I'm just going to use my finger, and it should play the, oh, could you guys go back for me? Let's see, we have a video there, but basically you're just going to look at the target and you're going to turn your head side to side, not super far. We want a small range of motion that you're doing and trying to keep your eyes focused on that target. And sometimes this can cause dizziness or imbalance just by doing that. So we typically try to work at a speed that's comfortable and then gradually progress that. But we also we want you to keep the letter in focus, which I'll highlight a little bit more later as well. ×2 means that the target and your head are moving in opposite directions, which I'm sure that might make some of you dizzy just watching me, right? So the importance of this is we aren't always, a lot of times we're tracking a moving target while trying to move our head, but you're keeping your eyes focused on it. So you're moving at the same speed, your head and the target are moving at the same speed, just opposite directions, so that way you can stay focused. And then if you can't see your finger and your eyes are somewhere else, then that's not what we're looking for. We want you to keep your eyes on the target. So, got it? Looks like fun, right? Okay. No. So here's a little video of that one where the target and the head are moving in opposite directions, and you can see how his eyes are staying focused on the letter the whole time. That's the goal. Okay. There's also gaze shifting. So if you have two different targets, you look at one and then move your head, and then look at the other target, move your head. So we're looking between two things. Again, if you kind of think of if you're like in a grocery store and you're looking between sides of the aisle looking for something, then you might look with your eyes and kind of then turn your head to look to see what's over there or to the other side. So it might not seem functional, but we definitely do these things all the time. And then the last one for gaze shifting or stabilization is where you try to remember the target. So you have those two targets. You're looking at one, close your eyes, and then we do that quick head movement, and you want your eyes to still be looking on the target you started with. So go ahead and try that. You have to remember which one you were looking at to begin with, right? But just another way to, whenever you make that quick head movement, sometimes you might feel that your eyes kind of try to go to the other target, and it's hard to stay focused and have your eyes open on that one that you started with. So some main factors with these exercises is not just doing them, but how we do them. We want to make sure that we have the head movement and the eyes staying stable, and that you're not moving too far. Sometimes you can get head or neck pain or a headache if you move too far or too fast or kind of jerky. So a lot of times we want to make sure you have that smaller movement, because we aren't typically moving quickly in a large range throughout our day. We also want to make sure that the target stays clear and in focus. If it's not clear, then your eyes are slipping off of the target. And so we want to start at a speed where you can keep that letter clear and in focus, and then gradually progress that. So that way you're getting that VOR function as we would like it to be functioning. In terms of how long and how often we need to do these exercises, about 1 to 2 minutes each. And then there's some different time frames for how long and how many weeks out that you want to do this. But if somebody initially has dizziness or just had surgery, then we want to aim for about 12 minutes a day at least. You can always do more than that, but at least 12 minutes a day. Chronic, so if it's been a few months after a surgery, or it's you've had dizziness for a while or imbalance for a while, then we typically want to try to get 20 minutes a day. And then if you have involvement on both sides, it takes the most practice and longer amount of time to see improvement. So 20 to 40 minutes a day in that situation. And then again, you can start doing these exercises as soon as you become dizzy, or right after surgery within a couple of days, kind of once the inflammatory process starts calming down and you feel more like doing it. But if you have dizziness or imbalance at any time, it can still be helpful. All right. And then the other portion of exercise, balance retraining. So we can do things in standing, like where you have your feet together, staggered stance, partial single leg balance, so where your foot's up on a step. We can stand on different surfaces, or you can also, like the foam, or a surface that can kind of move a little bit more, like a half foam roller. If you want to get really challenging, like a Bosu ball or something that's even more unsteady as well. But we can also change all of these exercises by adding in gaze stabilization, so those head turning exercises or just head movement in general while you're trying to keep your balance. So here's an example of doing that head movement exercise where your eyes are focused on the target with one foot on a step. So you're integrating both the balance and the gaze stability, or the half foam roll. And then another challenge, especially with some motion sensitivity, can be altering your base of support, so staggered stance or feet one foot in front of the other, and you can have a busy background as well, or a window or something else in front of you to have to focus on that target, make that more applicable to the daily activities in the community. And here's an example of not just standing balance, but more balance while walking. So walking heel toe or close to heel toe. And again, you can modify that depending how stable you are to start off with. And then head turns. This is something we do all the time with daily activities. So it's important to be able to move your head and see what's going on around you while you're moving. And then also turning around like your whole body in a circle. So we don't often turn completely around, but at least partially around, especially if you walk in a room, forget something, you have to go back and get it. I know I do that all the time, so. Okay, and I'm going to hand this off to Jennifer to talk about some outcomes.
All right, so as mentioned before, most of the assessments and things we do are, in the PT world, a lot of our assessments are a little bit more subjective, and how we prescribe exercises are based on expert opinion. I've been involved in some research at Johns Hopkins where we're trying to quantify movement in individuals with vestibular schwannoma in an effort to better understand relationships between how people are performing and feeling. And then that will help, hopefully, using these kinematic assessments, we hope to measure rehab outcomes more precisely, and then also make more informed decisions as clinicians when prescribing these exercises. So we've done a study in individuals with vestibular schwannoma, and we've compared kinematic assessments in schwannoma relative to people without schwannoma in older and younger individuals. And I'm just going to show a little illustration of our setup. We have people wearing 6 body sensors, 1 at their head, 2 at their trunk, and 1 on each ankle. And we have people doing these exact tasks that Kara just described, gaze stability exercises, balance and walking exercises. And then we extract that kinematic data and process it through a MATLAB code. And we have to segment every little step. It's a little painful. And we look at measures of asymmetry and movement variability. And we kind of try to paint a picture of trends, comparing the kinematic measures, again, of people with schwannoma versus not. And then we compare kinematic measures with clinical measures. And again, try to develop patterns to see if, how people are looking, and can we predict these movement patterns as to how they're going to do with rehab. The main finding we have discovered is that people that have schwannoma already have altered kinematics, and if they were to have the tumor removed, those maladaptive patterns stick around. So that's kind of one can argue maybe rehab before surgery would be helpful. So that's some little evidence that it's good to do these exercises really at any point. We also did another analysis, and we showed that doing the exercise where you're trying to focus on the target with moving your head more slowly it's a harder task than actually trying to turn your head quickly. And then we also did another analysis, and this is an example where we looked at all the different balance exercises, and we could identify which exercise was the hardest, and maybe that could help us inform that we should be giving people the more challenging tasks versus the ones that didn't necessarily distinguish the schwannoma individuals versus the non-schwannoma. The hardest task was standing with feet heel to toe and eyes closed. Although, as Kara said, When choosing tasks to do at home, you have to pick tasks that are realistic and doable and safe, that are right for you. The other paper we published, this analysis, we looked at people doing different walking tasks. One task was a very short duration versus a long duration series of walking tasks. And we found that the kinematic measures can be informative in ways, for example, we found head kinematic variability measure was more informative during a short duration task, and a range of motion kinematic measure was more informative during a long walking duration task. So we can better quantify and understand how people are moving than just our subjective kind of observation. And we can, again, measure progress and predict outcomes. So this work is to ultimately, better, again, identify people that are having maladaptive movement patterns amongst different patient groups, and use it for rehab in terms of measuring progress and predicting outcomes. So we've done a different analysis using machine learning. We're starting to do this. We're aiming to better predict patient outcomes and in healthy individuals with our kinematic assessments, and we're working to identify which exercises are most informative, which features or measures extracted from the data are more informative. And here's an illustration or example showing differences in kinematics, combined measures among healthy individuals, plots in blue and that top graph, versus schwannoma individuals in red. So you can see the red group is a lot more varied, and the unaffected individuals are pretty predictable in terms of how they move. And then we can, in the future, we hope to use kinematic data and machine learning to characterize kinematic trends to distinguish people that have schwannoma versus another diagnosis like a cerebellar ataxia, and that's in that little plot with the different colors there on the right. And then how is this important for rehab? Of relevance is, why do we care if we can tell if you have a schwannoma versus, and based on our data, and how that information help us with determining which exercise is going to be most effective, and how can we as clinicians leverage this information to better tailor rehab methods to help our patients. So that's kind of on our list to work on. And then in the future, with this information, we hope to make these tools usable in the clinic, helping to maybe limit testing time and improve accuracy. And this is just the start of our path of using such technology and analysis in the clinic. And perhaps in the future, this approach could be useful in the clinic where we can customize treatment recommendations, and we can have all these kinematic assessments all packaged up and then be put in an app where a provider can say, this is what the exact exercise a person should be doing based on their kinematic data. Anyway, so you might be wondering, do I really need to do vestibular rehab? And when we say that, we mean custom rehab, like going to an actual clinic and getting instructions by a therapist, or can you just do exercises on your own? So this was a study that looked in individuals with having had a schwannoma or acoustic neuroma resection. And they had 53 people in the group. It was a randomized control trial of two groups. One group just were given like a piece of paper or general instructions. Another group had one-on-one sessions with the PT. Measures that were collected include balance, confidence, and walking measures. And all subjects improved within 6 weeks after surgery. And of the older folks of each group, the ones that had received the custom rehab did a little bit better than the older ones that had just gotten the general instructions. And those results maintained after 1 year, which is good. And then this is a really nice study. It was the first reported study of efficacy of vestibular rehab in improving function in patients with NF2. Kara found this study. Thank you, Kara. 21 individuals with NF2 were enrolled. They did a PT, a regular 1-hour assessment, and given a customized home program. And they did identify that almost everybody were identified as being at risk for falls. And with rehab, almost 80% of the group improved with rehab, and those improvements were maintained at 9 months after, which is amazing. And the individuals, similar benefits were seen across everyone in the study, irrespective of their age or genetic severity or their symptoms, which is really great. This was a study that I was involved in where we had 43 individuals that had vestibular schwannoma tumor removed, and they were enrolled in rehab 6 weeks after having had surgery. So 19 folks actually completed this study, and the program that people did and we had them in clinic doing, we worked on them one-on-one, but giving them a relatively standard program of gaze, balance, and walking exercises 7 days a week for almost 30 minutes per day, plus walking. And so we collected measures of how people were feeling, how they're performing, and their physiology. And this is an example of somebody's physiology before and after the therapy. And as Dr. Shu said, this vestibular ocular reflex gain is a measure to see how well the eye and head are coordinating and the timing of the ability of the eye to move with quick head movements. And in this person, that measure did improve from 35% impaired and it improved up to only 58% impairment. It improved to, their timing got better, and their brain's ability to sense that something wasn't perfect and make a compensatory eye movement was quicker. So that was really great. But the interesting part was, as a group, this physiology didn't change. This is a table showing the change in that study of how people were feeling and how people were doing. So as a group, people did feel better and they were performing better, which is awesome. So it might have not been because, we don't really know why. Maybe some part of their physiology did improve. So that's another, plus for doing exercises and rehab and keep moving. So all those measures did improve at a level of statistical significance. So the key for successful rehab is to work with a physical therapist who can give you a program that's right for you, because everyone is functioning at a different level, everyone has different needs, so it's hard to just get a piece of paper and be told to just go do this at home. It really helps to work with a therapist that's trained in vestibular rehab. And the earlier you start with rehab, the better, and that's been shown in a lot of different studies. The training effects are context specific, so if you train your eye and head coordination at a slower head speed, that's the way the brain is going to adapt. But then if you test them at a faster head speed, but you haven't trained them at a slower head speed, it might not reflect in the test that you actually did better. The other example is if you were to have surgery, not everyone's a candidate for surgery, but maybe you've gone home and you practice all your exercises in your house in the comfort of your home, and then you suddenly navigate outside and you're dealing with uneven sidewalks or wind or noise, then your brain is like, oh my gosh, and you might feel like you're getting worse, but really your body has never been in that context or situation, and you have to train your body in that situation, again, to see results. And so you're not necessarily getting worse, you just have to practice in those different environments. So in the clinic, we try to simulate every life situation, but that's not always, sometimes, so it's a combo of doing this custom exercises to get you set up for success, but then gradually returning to things that you're comfortable with. Motor learning can happen at any age, and you have to challenge yourself for you to get better, but of course, we don't want you to be challenging yourself to the point of worrying about a consequence of a fall. All right. And then, as I said, if you were to rate yourself in terms of level of difficulty when you're doing exercises, 0 being pretty easy, 10 being really hard, we want you to exercise at a level 6 or 7 for you to actually get benefit or to move the needle towards making improvements. And again, you have to be the judge as to what's realistic and safe. All right. And for the effects of rehab to be effective is, again, you have to keep challenging yourself over a lifetime, but keeping up with a home program can be tough. I'll admit vestibular rehab exercises aren't all that exciting. So adjunct treatments can help sustain activity over the long term, and especially in children, maybe use of video games, but Tai Chi, yoga, Qigong can be really helpful. But the thing with vestibular rehab and challenging your vestibular system, head movements are a key part of that. So with yoga or Tai Chi, doing some of those poses and adding a little head movements will help get the added vestibular challenge. All right, Kara and I are going to go back and forth here. You're going to come over here.
Okay, so there are some barriers to exercise. Like we said, they're not the most fun, but there can be other barriers as well. So motivation with the exercise, or if we can make it more applicable to like daily activities, that can make it easier to see, but sometimes they're not the most exciting. So trying to find a good way to motivate yourself to then put in the time that it does take that we've highlighted earlier to see improvements in function. How much time you can carve out during your day. So you don't necessarily have to do it all at the same time, but if you can chunk it up and fit it throughout your day and schedule to see those benefits. Pain or headache, so especially post-op, you can have a lot of tightness in the neck or pain or discomfort. So that can be a barrier to exercise as well. Safety or fear of falling. We are trained to help set up your home environment so that way when you're doing your exercises, you can keep yourself safe. But sometimes it takes a little bit of time to get used to that if you've been feeling really dizzy or off balance or have a fear of falling then. And then overall fatigue, because your brain is working harder to try to adapt and compensate for all of the different sensory involvement that we have with trying to retrain the vestibular system. So all things to consider there.
And then when it comes to kind of starting rehab, it's really important for you to kind of identify what is most important to you to work on, what goals do you have? And we want you to kind of be realistic with where you're at. And so, that's kind of important to start off with. And then good to communicate goals to others to kind of keep you accountable. And to set short-term goals first, and then keeping those long-term goals in mind as you chip away at those short-term goals one at a time. And make modification to your goals. Not every day is a good day, and sometimes goals can be just on a day-to-day basis. If you're not having a good day, still make sure you set yourself up to do at least something, but it might not be what you thought you might be doing, but still just keep, and then consider safety at all times. Be realistic on how your body's functioning, and make decisions in real time of what's realistic and what's safe to avoid falls.
Some other considerations, like we talked about your goals, adjusting your expectations. So if you're having a day or a week or so where you're not feeling well, do what you can. Tracking your progress, or have somebody to keep you accountable, whether it's an app or a tracking log, or just having somebody at home or something you can mark off on the fridge to help see something every day. Not every day is going to be, you aren't going to see as much of a change, but trying to find something every day that maybe is going a little bit better. Consider that if you do have a vision impairment, like balance is going to be more the focus than gaze stability. And because without the vision part, then we can't really work on the gaze stabilization, but you can still work on balance and try to improve how stable you feel. And it may take longer if there is involvement on both sides. And then if there is anxiety or depression present, then also trying to get treatment for that, because that'll definitely affect progress. You can decompensate if you don't keep up with exercises, so try to stay active and do them long term.
Okay. We are just at the very end.
We're at the very end. Yeah.
Thank you. So if you are having any secondary musculoskeletal kind of issues, we want to make sure that that's not a barrier to you doing the eye-head coordination and balance exercises, so it is important to have that addressed. So you can seek advice from your doctor. You can seek a referral for PT. And, you know, and PT can help you with some stretching exercises, some cervical stability exercises, some self-massage techniques. The good old put 2 tennis balls in a sock trick and then land, that could be a nice way to just relieve some stress in the back of your head. And then again, fatigue is part of living with this sometimes. We hope that endurance and aerobic exercise can help you manage that kind of non-motor symptom. And you can, you know, it might help you be able, and then any other strategy you can implement to help you conserve your energy, we encourage. And then cardio is just good across the board for like everybody for so many reasons. So we all in this room should be doing cardio regularly. So yeah, if you're just doing stationary biking, that's not going to necessarily, alone, you have, it's not going to help you with your eye-head coordination, but it can certainly, so anyway, you got to do it all.
That's okay. So here are some resources that they're included in the slide deck that you guys can look to if you want to try to find a provider. And then also other, oh, yep. I was like, it should be in the app too, but there you can take a picture of it real quick. Yeah.
The point with this is for vestibular rehab, you really need to work with a therapist that is specialized and trained in vestibular rehab. So the Vestibular Disorders Association website can help you find a vestibular therapist, but they can also tap you in with otologists, audiologists. They're a great resource.
For sure. And there's lots of other providers that can be a big part of your care team. And
so in general, with rehab, people can feel better and do better and keep doing what you enjoy doing within your ability. Be safe, don't fall, but keep living your life.
keep moving, and then if you just want to
Yeah,
say.
sorry. We just want to thank everybody for inviting us here to be able to talk to you and kind of bring more awareness to this topic. And I think we have just a little bit of time for questions, so we're happy to entertain those.
All right, we did have 2 questions that were in the app. One of them, with balance exercises, how do you start or do these if even just standing up and crossing your arms causes an imbalance?
Well, you want to practice what's hard for you. Being in the corner of a room is a great safety zone where you have a wall on either side of you and behind you. And if you can't, you got to see where you're at, and then choose a challenge that you can do that's, again, in that 6 to 7 level of intensity. When we say intensity, we mean that we want you to be challenged to get better, to make improvements. Intensity can be in terms of balance confidence also. So maybe start with your feet wider and then start to bring them a little closer. When you master that, bring them in just a little bit, a little closer. And then eventually you can add a little head turns. And you got to decide on what velocity or amplitude you move your head, and you can make adjustments, whether harder or easier, depending on how you're feeling and doing.
Mm-hmm. Yeah, and so I would say, if there's concerns about even doing those at home, obviously, speaking with your one of your doctors to get a referral to a physical therapist for vestibular rehab is important. And then, again, regarding the intensity, I always like to tell patients that you want to feel uncomfortable but not unsafe, and that's kind of the space that you want to be in when you do these exercises.
So I've had 5 acoustic neuroma surgeries in the last 5-6 years. So I've obviously need a lot of therapy. Yeah. And we looked everywhere. I live in New Jersey, but right outside New York. We looked everywhere in New Jersey and couldn't find a vestibular therapist. And finally we found one, and it was like 35 minutes away from our house. I'm wondering, how do you think in school for PT they can promote vestibular therapy to make it nor just, nor, you know, I'm blanking on the word.
Yeah.
No.
Sorry, you can go. Were you still going?
I think she's done.
Okay. We are all trained a little bit in school, but it just depends on what people are interested in and the need of the community, kind of what path we go down. But every PT school, like, we are introduced at least to vestibular rehab, but it takes some practice, and it's a very complex area of practice. But I completely agree. More people, there's a big need for vestibular therapists, and so I think the best thing we can do as providers is just to continue to be in touch with the school and the students that we help train, trying to educate them more on it and the need for it. But I think there has also been a lot more research recently in vestibular rehab, so hopefully there's more therapists that are going into that area.
Yeah, and in terms of access to care, one thing that came out of the pandemic is the access to virtual visits. So if you live 5 miles away from a therapist, maybe go into the clinic for the initial visit, but then follow-ups could be scheduled over a virtual session.
One other question that we had on the app, are there any known connections between NF and either POTS or POTS? I'm not sure which way you say it.
Oh, I don't need that. I talk.
Oh, okay, never mind.
I'm just wondering if these pictures will be wired on the app after. I know they were going by so quick. I didn't get a chance to take pictures of everything.
Yep, the slides should be in the app, yes.
I was just wondering if the pictures would be on the app after. Everything was going by so quick with links.
Yes, they are.
Yes. Yeah, and I think to address the POTS question, I'm not sure, we were all discussing this a little bit earlier, I'm not sure if there's a direct connection there or not, although something like POTS can make the imbalance and dizziness that a patient may be experiencing otherwise, more impactful for them. POTS tends to be a different type of dizziness, more of a lightheadedness or pre-syncope, the sense that you might faint or actually faint, and so that definitely does not help the other symptoms that you're also already experiencing.
All right, thank you so much. We are at time, so there's a 10-minute break right now. The next session will start at 11:30.